Good afternoon, ladies and gentlemen, and welcome to this meeting of the Perth Kinross Integration Joint Board of Wednesday, the 20th of August 2025. Apologies for the late start. There were IT issues with the preceding committee meeting this morning here in the chambers. Can I just check quickly for people online, could somebody just give us an indication that you're able to hear us okay?
I can hear you fine.
Yeah, I can hear you too.
Thanks, Val. I think we're still looking to get Heather Duncan to the meeting, are we? Okay, so Ms. Dunk, not in yet, but we're trying to get her to join. Just to introduce a couple of new faces today. We have Shahina Din from PCAVS, who's stepping in as the third sector rep for this meeting in place of Melanie Devlin. We have Dawn Wigley joining us as an observer, who is the service manager for prisoner healthcare. And we have Marion McCardle, who is a member of the Interim National Care Service Advisory Board. Marion's an advocate for those who need additional support using social care services and has been actively involved in the Social Covenant Steering Group on the development of the National Care Service. So welcome to you as an observer for our meeting today. Thank you. I don't believe we have any other apologies or substitutions. All right, okay. Apologies from Nettie Sutherland, one of the public partners, and Heidi Douglas, representing Public Health. Are there any declarations of interest in items before us on the agenda today? Not seeing any. Okay, we'll move on to the minutes of the previous meetings. Can we agree the minute of the IJB from Wednesday, the 4th of June? And can we agree the meeting of the minute of the special meeting of the IJB on Friday, the 20th of June? Oh, Mr. Riddle.
Sam Riddle. I joined that online just for the completeness of the record. Yeah.
Thanks. We'll make a note of that. Okay. We'll move on then to the action point.
Yeah, on page 9, in response to a question from M. Summers regarding whether joint meetings of the affected boards will be called, Jackie advised that she would discuss a requirement for this with the fellow chief officers. I just wondered if it had been decided that that would happen.
Thanks, Maureen. That's been added to our action log, and the update that I'll say now rather than repeat it later, if that's okay, Chair. I have discussed it with the other chief officers, and I've also mentioned it to the chief executive of NHST side to consider that wider perspective from NHST side forward. And there is a keenness to progress with that, but at the right stage. Whether we've got the right timeline here is yet to be determined. Thanks.
Okay, thank you. We'll move on to the action point update. The first is a presentation on Sharing Care Together about supporting continuous participation and engagement of people with lived experience. That should be provided to the IJB, and a short video was circulated following our June meeting. I think that was following the first June meeting. and materials supporting their summer tour have also been shared with IJB members, so we'll close that action. And on the Tayside Mental Health and Learning Disability, a combined Tayside-wide meeting to be held in relation to model of care, and that was the update that the Chief Officer has just provided. Okay, so are there any matters arising from either the minutes or the action point update? Nope. Oh, sorry, Chief Officer.
Yes, thank you very much, Chair. Really just to draw attention to the second minute where there was an indication at that time when we met on the 20th of June that we would be holding a further public meeting with the registered patients and public in relation to the CARS medical practice, along with community councillors and local elected members. Over the summer period, the announcement of the outcome from the CARS contractual arrangements were communicated to the community, and that allayed concerns, and there was no further need for a public meeting. So I think we just should have that on record that wasn't held, and it was by agreement with the community. Thank you.
Thanks. And I think it's thanks, Jackie. And I think certainly from having talked to my councillor colleagues from the Carse of Gowrie, people's concerns have been greatly alleviated by the announcement that was made. It's a great result and a great outcome, I think, for the Carse medical practice and for the residents of the Carse of Gowrie, or at least for that central part of the Carse of Gowrie. Previously, when we have discussed primary care and GP continuity and sustainability issues, we've had lessons learned when we've had closures of practices. I think that this process has worked really smoothly this time, and it's achieved a great outcome for the residents. And I think it would be actually advantageous to hold a lessons learned meeting on how things have gone well, as opposed to when they've gone badly, because we need to learn and embed that practice and continuous improvement. So would that be something we could entertain?
Thank you very much, Chair. That's something that I know colleagues in primary care and with Tayside Primary Care Services have already been in discussion, and there will be a lessons learned exercise carried out, because although this did result in a very good outcome, there are lessons to learn from that, but also there will be significant areas that we can still do better on this one. So yes, that will be an exercise we'll carry out. I think it would be helpful for the IJB to see the outcomes from that at some point in the future. In fact, that should be shared across all of the IJBs and NHS Tayside board, given our different responsibilities there. So I'll request that that's shared at some point when that's complete. Thank you.
And I think maybe we don't need to add that to the action point log, but we could put it on the forward meeting planner as a report to come in future. Thank you. Board, with your permission, I'm going to vary the order of items on the agenda today. The Chief Finance Officer might need to leave later in the meeting, so can we agree to take the 25-26 financial position first before we move on to items in section 6 on the agenda? Thank you very much. Chief Finance Officer.
Thank you, Chair. Very much appreciate that. Good afternoon, everyone. This report is the first financial update for 2025-26, and this forecast is based on the first 3 months' expenditure. This is actually the earliest point at which a financial position has been presented to this IJB, and I would like to thank the teams involved for all the work that has gone in to bring this early position to the board today. When the budget was approved in March, it was balanced according to a medium level scenario of anticipated pressures. Several potential risks were identified if a high-level scenario developed, and that was particularly regarding demand. And these risks are now starting to materialise. For 25-26, an overspend of just over 5 million is currently being projected, which reduces slightly to 4.9 million after using the small amount of remaining reserve. The main areas with increased expenditure are set out and explained further in the report, but in summary, they are care at home, which continues to experience sustained demand, adult care packages in both residential and community settings, and staffing pressures in our inpatient services. These pressures are outweighing the additional funding and the savings we planned for when the budget was set in March. Although this is a very challenging financial position, it's important to note that this is a result of services continuing to meet the needs of the people requiring health and care. There are low levels of unmet need, and as seen in the care at home position, and there is strong performance when considering the whole system flow overall. I'm also keen to note that the prescribing position, which took up much of our focus last year, is currently projected to be balanced and in fact has a slight underspend at present. But while the position is very challenging, it's also important to stress that nationally, the financial position for health and social care is extremely challenging and very similar to what we're experiencing in Perth and Kinross. With demand for services continuing to rise while increased costs are putting pressures on budgets, and the Accounts Commission recently reported that the collective funding gap nationally is well over £450 million. And this is not an isolated issue, and what we are seeing in Perth and Kinross reflects this wider issue. The IJB's financial risk is rated as very high, reflecting the seriousness of the financial situation, and a financial recovery plan is one of our key controls. The senior management are already taking steps to manage the overspend, and that will include reviewing of packages, controlling supplementary staffing and accelerating any improvement and transformation work. But it's important that we note that much of the increased expenditure is driven by need and acuity, and this limits what we can achieve in the short term without detrimentally impacting service delivery and the whole system effectiveness and flow. Consideration will also need to be given to assessing our capacity to deliver improvement and transformation whilst we manage increasing demand and complexity, and we need to identify what is needed to address this. The IJB is therefore recommended to request a full financial recovery plan to be brought to the board in October to set out options for addressing the overspend. There's been quite a wide amount of work, I would say, a detailed amount of work going into preparing this report. So I'm going to invite questions, but Mark and I might do a bit of a double act in responding to any financial related questions. Thank you.
Thank you. Do we have any questions? I've got one. When ever since I first joined the board back in 2018, I think it was, the prescribing overspend has been a continuing issue, and I know that there's been the QSEP programme and various improvements to the prescribing, and I just wondered what it was this year that has made the difference in terms of getting that recurring overspend under control.
There's a couple of things. So the first and probably most significant thing is to note that additional funding was provided by NHST side, and that was to address the parity of NRAC within Perth and Kinross. So that's made a significant impact, but also the position is reliant on the strong engagement that we've had with the GPs in Perth and Kinross and the investment around the QSEP programme, that we are relying on efficiencies coming through from that investment. But Hamish, do you want to come in as well?
Yeah, I think there's been two key programmes where drugs have come off patent and have involved quite a lot of work, because you can't just write a letter to a patient and say we're switching to another drug. There's a whole conversation to have with patients. So it's been a big bit of work for GPs across P&K, but the practices have really engaged in that, and that's brought recurrent savings to us. But it's a shifting sands, because things will change and they keep changing. So it is frustrating, but we've had really good engagement from colleagues.
Thanks, that's good to hear. Mr Black.
It's an item 3.3, which is about staff vacancies. We're still looking at, but then we go into staff to item 3.5 and 3.6, where we're talking about supplementary staffing over and above. Is that because of sickness? Is that because of the changes in the packages, and the packages that we're getting seems to be significant, a significant increase? Are they being monitored into our flow, or do they just hit us?
I might be able to answer some of that, Martin, and then pass over to Jane or Zoe for the rest. On 3.5 and 3.6, that is their costs that we're seeing around our psychiatry of old age services and our community hospital services. And much of the reasons has been, yes, sickness, but also increased acuity that's been experienced in both the areas. So just to be clear, that's that part. But for the rest, I would pass to Jane.
Sorry, I'd absolutely agree with Donna. So, for example, in psychiatry of old age, we're experiencing much higher levels of need, and this is placing considerable stress on the members of staff. Although they are an excellent team who achieve excellent outcomes, they are working within considerable pressure. So quite often what that means is the absence levels then mean that we have to put additional staffing in place to maintain patient safety. Previously, that was mainly through agencies, but that's particularly expensive. So now there's been a transition to bank staffing. The next step is to look at what we want the service to look like in the future to make sure we maintain good patient care, but at the same time safeguard our workforce. So it is quite a difficult situation, but it's a direct result, as Donna was outlining, of the pressures that the services are facing at the moment.
And do you want to add anything?
No, I don't think I would add anything to that particular element, but 3.3 makes reference to care at home services due to staff vacancies and turnover, which is sort of par for the course, to be quite honest, that level of turnover that we have in there. And there's obviously a mitigating to that additional pressure, but there's nothing abnormal within that, if you like, Martin.
Thank you. Sorry, just one more quick thing, just to give you an idea of this challenge that I'm explaining, is what we're also experiencing is because of the level of acuity individuals, then the level of observation they require for them to stay safe is increasing, which means that we have to bring in more staff than you would normally see on a shift.
Thank you. Oh, do you want to come in, Chief Officer?
Yes, thank you. And I think, Zoe, in terms of considering the community hospital element of this, where we've got 4 community hospitals quite far spread in rural areas, so the ability to have staff cover resilience across that is actually pretty tight, and that's something that we've been looking at for some time. So I think that contributes to the requirement to bring in supplementary staffing, because you can't. It's easy to, if you're in a larger hospital, it's easy to move staff across ward locations. It's not really possible to move across from one locality to another because of the distances involved. So do you want to say something about that?
Nope, not really. I think you've encapsulated that quite well. Thanks very much for that.
Councillor Frampton next.
Thank you. On page 62, 5.4, one of the bullet points points to non-based pay uplifts. And it states, although funding has been received for Agenda for Change and medical staff funded through core baseline budgets, 2025-26 uplift funding for non-baseline posts have yet to receive a funding uplift. I was just wondering, what is the non-baselined posts?
Thank you for your question. Non-baseline, what we're referring to there is the Primary Care Improvement Fund, the Alcohol and Drug Partnership Fund, and the Mental Health Action 15 Fund. So attached to those funds are posts which require uplifts as well. Not uplifts passed forward from Scottish Government and NHST side. So we've yet to receive that yet, but we're just highlighting the risk of that potentially not being received. Thank you.
And Vice Chair.
Thank you. I just wanted to ask how we're managing the risks within the league partner arrangements and the increasing costs. Are we monitoring those through some kind of formal mechanism?
Yes, thank you. We do have a regular, what we call a lead partner meeting, which is attended by representatives across the 3 health and social care partnerships, including chief finance officers. So that's where we manage those in-year, if you like, issues as they are arising, and work together collaboratively to manage that.
Mrs. Summers.
Yeah, you talked about, having to bring in bank staff rather than agency staff. Is bank staff still not very expensive? And when are they going to consider looking at the amount of staff and how much extra staff they need? Because the problem's not going to get any better with the, psychiatric old age. It's going to get worse.
Yes, I agree that you pretty much encapsulated the issue, which is, yes, bank staff are expensive, which is why we're looking at alternative way of modelling the service. There's a number of issues within this as well that look beyond just the staffing levels and the model that will be most sustainable and achieve the best outcomes for individuals, given, as you say, that the situation is only going to get more demanding. So that's one of the elements that's outlined within the adult redesign paper for your consideration today, and we'd be looking to work up a more detailed model to present as we move forward.
Councillor Illingworth.
Thank you, Chair. It's a question for Hamish, actually. How are GPs getting on with managing polypharmacy?
Don't know, Danny, do you want to pick that one up? I think it's a constant part of life. I think if this is an economic question in terms of, in the context of a budget, I think polypharmacy reviews are really more a quality improvement initiative rather than a cost saving initiative. I think very often when you do reviews of patients, you might actually end up with more drugs or more expensive drugs. So it doesn't de facto mean you'll save money by doing a polypharmacy review. I think the point of polypharmacy reviews are to reduce risk and approach it with a realistic medicine approach, so that you're making sure that patients are on the things which are actually going to help them and that they want in an informed way to be on. So there is a programme. I mean, most practices will do polypharmacy reviews on a regular basis every time a drug is reauthorised. But I don't know if Danny wants to come in at the moment.
Yeah, I think it's an important question. I think it does come down in some way to the organisation of the practice. But as Hamish says, there will be regular medication reviews. E-prescribing can sometimes be a challenging topic for patients, but it perhaps is something that we should be having a bit of focus on. So whether that might be something for the QSIP projects to look at. I think there is quite a bit that does already go on as part of their annual reviews, but as people are living longer with more and more conditions, it's inevitable that they'll end up on multiple drugs. Lots of these drugs are to reduce further problems for the individuals to improve the quality of life. I guess the question is, once they get to that stage of life where they're becoming increasingly frail, do they still need all those drugs? What we try to prevent, and that's where I think perhaps looking at de-prescribing projects might be quite useful at some stage.
Second question from Mr. Black.
Related, but in adult services, we seem to be getting better at identifying the packages that are required but where we seem, while we're getting better at doing that, we don't seem to have the staffing levels that can support that. In that redesign, do we then need to look at how we're going to increase that staffing level to support that increase, or the success in trying to find out that? And, or is the people who are coming into adult services the people that have come up from education and landing on us, and the money's not followed them? I'm a wee bit. We're being successful, but to continue being successful, how we're going to support them?
I could answer that to a degree for you. This is an area that is really challenging nationally. So there's a number of work streams that we're taking forward to better understand the demand, so that we can be pre-prepared for it, pre-warned in a way. We're looking to work very closely with colleagues in children and young people services, in housing and education, to try and look at different ways that we could work collectively, so that we could try and manage the situation more easily. I think the sort of non-negotiable or the particular issue within here is, regardless of the service redesign that we do, the level of need and the associated costs is phenomenal. And I'm sure you would agree that what we're really aiming to achieve is to provide the best and most appropriate quality of care possible. And that puts us all in really quite a challenging position. And I would go so far to say that sort of principles at the heart of the challenge that we have with services and financially at the moment. So you're seeing a lot of redesign work being presented to you, and but that is still only one tool. That's one way that we can look at this, but probably not one that's going to completely address the issue that you outline.
Okay, thank you. I'm not seeing any other requests for a question. Are there any comments on the report? Okay, not seeing any comments. So can we, thank you very much for the report. And can we note the overall projected outturn for 25-26 based on performance to the 30th of June? Note that NHS Tayside set its budget on the 24th of April, and delegated budgets to Perth Kinross IJB are in line with planning assumptions for 25-26. And can we note that senior management are working on actions to mitigate cost pressures in the current year, and that the Chief Finance Officer has advised NHS Tayside and Perth Kinross Council of the projected overspend, and can we request the Chief Officer and Chief Finance Officer to present a financial recovery plan to our next meeting of the IJB in October 2025. That's agreed. Thank you very much. So similarly with that report and moving it up the agenda with the board's agreement, I'll move up 7.3, which is the Audit and Performance Committee's annual report for 24-25, and this is the other one that's going to be introduced by the Chief Finance Officer.
Thank you. Thank you very much. Thank you for taking the time to review this report. This is the annual report from the Audit and Performance Committee, and apologies that Phil Gerard isn't with us today. He certainly would have helped me introduce this report, but I may rely on Councillor McCall if there's any other questions that I can't answer. The report highlights that the Perth Kinross Integration Joint Board's Audit and Performance Committee's commitment to ensuring effective governance, risk management, financial oversight and performance monitoring for health and social care services. The committee consists of voting members from Perth Kinross Council and NHS Tayside, along with non-voting members. During the 24-25 period, the committee met 6 times, including extraordinary sessions, to review governance, audit, performance and finance reports. Regular reviews of the strategic risk register, and improvement plans were conducted with full completion of prior year governance actions. There were 4 assurance reports for clinical and care governance, and the annual governance statement confirmed that there were effective internal controls. The committee monitored the IJB strategic risks, approving a risk appetite statement categorising risks across key areas, and a new strategic risk register was adopted to align with the updated strategic plan. The committee approved the 24-25 internal audit plan, which focused on key risks and received progress updates, and the Chief Internal Auditor affirmed reasonable reliance on governance and control systems. Audit Scotland, as external auditors, reported unmodified opinions on accounts, confirming effective financial management and governance. However, financial sustainability, as you've just heard, remains a concern with projected overspend and the need for service redesign and additional funding, and the 24-25 audit is ongoing. The committee also reviewed national performance indicators and strategic delivery plans, and the 23-24 annual performance report showed positive progress with targeted improvements identified. The financial position reports were considered, but as you know, they are now being reported directly to the IJB meetings. But in conclusion, the report provides a detailed review of the committee's efforts and achievements in governance, risk management, financial oversight and performance monitoring. Thank you.
Are there any questions? Or, sorry, Councillor McCall, I don't know if you wanted to add anything.
I was going to say something in my verbal update, but that's kind of slipped a bit, so I'll reword that slightly, but basically just thanks to all the officers.
Thank you very much. Mrs. Auld.
I think there had been a call for a new member for this committee, and I just wondered, had that been progressed or in progress? Yes,
Okay, I think that will be covered in Councillor McCall's report later. Councillor
Thankfully, the Audit and Performance Committee is generally not very exciting, which is great news. And I'd like to thank Councillor McCall for her work as chair.
Not seeing any further questions or requests for comment on this report. So can we note the report and agree to the level of assurance provided by the chair of the Audit and Performance Committee as outlined in the conclusion? And can we acknowledge the work and commitment of the Audit and Performance Committee members? And I think, as Councillor McCall said, all of the staff that contribute to the report. Yes, agreed. Thank you very much. Okay, we'll move on now then to the Chief Officer's strategic update, and we have it in written form this time. But Chief Officer, would you like to introduce?
Yes, thank you. There was quite a wee bit to draw to your attention at this meeting, so that's been prepared in a written report. It's usually a verbal report. It provides an update to the members of the Integration Joint Board on matters of strategic importance and includes information across a range of relevant policy updates which are relevant to the strategic planning for health and social care. The IJB's asked to note the strategic update, but I'm also suggesting that the IJB seeks a further report on the implications of the Health and Social Care Renewal Framework, a more detailed report to a future meeting once the Health and Social Care Partnership has an opportunity to assess that in a bit more detail against the current strategic plan and also our transformation programme. The first item relates to the publication of a suite of 3 interrelated documents in June 25, or the majority were in June 25. The National Health Service Scotland Operational Improvement Plan, which describes short-term commitments and actions across NHS Scotland to improve the experience of patients in the IJB, had a brief update in relation to Scottish Government funding as part of that improvement plan, and the outcome of a funding application via the whole system application by NHS Tayside and the 3 health and social care partnerships at our development session on the 15th of August. And then there's the Population Health Framework, also published in June, which is long-term cross-government and cross-sector approach to improving health in Scotland, and the Health and Social Care Service Renewal Framework, which sets out a long-term strategic intent and provides high-level guide for change across health and social care. And if you've had an opportunity to look at that document, there's a link in the report. I'm just going to read a section from that, which states, I did have it in front of me. Sorry, I've lost my placement. But basically what it says is that this document is actually a really important step forward, and important for NHS boards and integration authorities in terms of their planning for health and strategic planning and meeting population needs over the next 10 years in Scotland. And it might be helpful just to pause there before I move on, Chair, because there's quite a bit of detail in that, but I'd like to just ask if that would be appropriate to bring forward a more detailed report to that to our next meeting or the meeting thereafter.
It's nodding.
Yeah, okay. Just to reference for awareness are the findings of the NHS in Scotland, a spotlight on governance, which was published by Audit Scotland in May 2025, and the findings from that have been incorporated into the service renewal framework. Also a brief update on the a progress update on the independent review of inspection, scrutiny, regulation of social care in Scotland was published in June 2025, reflecting a shift towards a more transparent, inclusive and outcomes focused regulatory system for social care in Scotland. That's there for your awareness. There was also a review of social work governance and assurance published by the Care Inspectorate in May 2025. Which found while social work governance structures were mostly effective, there were challenges ensuring that social work has equal influence across within health and social care partnerships, and in managing significant staffing and financial pressures, which is pertinent to the discussions we've been having today. And within that, there was a staff survey which was reported Scotland-wide, but we've had a bespoke report locally, which was very positive, I think, in terms of comparison to the national picture. And that's there for your awareness. An update on the Care Reform Bill, also for your awareness. And a bit more detail in relation to our engagement with the Care Inspectorate from regular liaison meetings in order to take forward some joint collaborative work. Aaron Singh, as Chief Social Work Officer for the Council, and myself meet regularly with the Care Inspectorate, and we've agreed to do a joint piece of work into what we're seeing as a falling trend in relation to gradings for care home or care services in general, but care homes in particular. those grades are the number who are being rated as good and above are going down in Perth and Kinross, which is actually against the trend of our comparators. So we're going to work collaboratively to get underneath that in a bit more detail and to do some work around enforcement and large scale investigation and learn some lessons from some recent experiences that we've had locally. So that's really good to see that piece of work with the scrutiny body in terms of helping our improvement journey. So we can report on that in due course, and it might be something that you would include in your Chief Social Work Officer's report. And just noting that we responded very well to the summer storm Floris, which was only just a matter of a few weeks ago, where we managed to ensure that all of our activity across the Health and Social Care Partnership took place as business as usual activity, and that was maintained throughout the storm with minimal adjustment to service delivery. So we need to commend our managers and staff for their approach to that, and as usual their step into business continuity. And just two areas I've actually skipped over something, so I'm going to go back because it relates to our discussion about psychiatry of old age and the pressures there. There is a report that's been published today on the Mental Welfare Commission's website, an inspection of leave-in ward in Murray Royal Hospital in May 2025, and this report indicates that the verbal feedback was positive. The published report indicates that the service at that inspection required no recommendations from the Mental Welfare Commission, and that's actually a pretty unusual event, and something to commend to the members of the Integration Joint Board. I popped up to the hospital to congratulate the staff last week. I think that's quite an achievement given the pressures that they're experiencing. So I think the financial pressures and the staffing pressures, I think we've got evidence there that that's not impacting on the quality of care for our patients in that particular ward. And just a reference of an invitation from MND Scotland, Motor Neuron Disease Scotland, inviting Perth and Kinross as a whole system or a multi-agency participation in developing a good practice example for Scotland across local authorities. So that invitation I think was very welcome, and we will take part in that, but I think to be recognised in that way is quite significant too. So those are the key areas of my update for you. Thank you.
Thank you very much, Chief Officer. It's great to see, just on those last 2 points, it's great to see Perth and Kinross being recognised as sector leading in terms of the MND Scotland good practice case study, and in terms of the lack of any recommendations from the Mental Welfare Commission for leave-in ward. As a former quality auditor, it's pretty unusual for there not to be any recommendations coming out for inspections. That's really commendable. Councillor McCall, you have a question.
I have, thank you. It's to do with the work with MND Scotland. It seems like a while ago, Jackie, since we met some families of MND sufferers that we started conversations with, so we've come a long way. But I think it would be interesting to know how we can use that experience to provide a similar level of service and acknowledgement for other patients suffering from a similar progressive neurological condition. Thank you.
I think that's a very good question, and I wonder if we actually build that into this experience in terms of we're bringing different practitioners together around this to think about what are the constituents of good practice. Then the next step to that would be, so how do we exploit that further?
Yeah, I think so. I mean,
just for the restroom, I think a lot of the reasons we've got this far with MND is because of the lived experience and the testament from people who have lived through that. But also because of that, being exposed to what others didn't do so well. And so I think if we can reach out to some of those organisations, we'll be able to start seeing where the commonality is, because there's actually an awful lot. And possibly as well also working with our colleagues in health, because you know, I know in housing we're doing that sort of work already, but I think there's a real opportunity here to build on that and make it a much wider profile, so that as many of our residents as possible can benefit from the good work we're doing with the MND Scotland. Thank you. Thank you, Chair.
Looking around for Mr. Henderson.
Jackie, just you know, about the care and spectrum grades, it's good to see a collaborative approach. It'd be good to get a deeper dive into that, and more than happy to be involved. I think looking at the grades under good, but also allow the opportunity to look at internal factors within the care homes, but also external factors that might be caused the pressure, and obviously this wider scope as well. The Care Inspectorate did their care home improvement programme in Tayside and Fife and finished in March. That was with care homes that were seen to be ready for improvement with grades under adequate. So it'd be good to discuss with them the impact and the tools they used for that. And obviously the opportunity to look at care homes that the grades have increased or are sitting at 5 and 6. What's the difference between the ones that are not got those level of grades? So I think it's an opportunity to get a deeper dive into the grades. That was it.
Thanks very much, Dave, and very happy to include you in that at the most appropriate point. Thanks.
Not seeing any more hands go up or requests in the chat box. So can we simply note the Chief Officer's strategic update with the note that we'll get a further report on the implications of the Health and Social Care Renewal Framework to a later meeting of the board. Thank you very much. Next on the agenda is the Tayside Mental Health and Learning Disability Services strategic update. I think we had a verbal report last time, so we've got a written report this time. Is it yourself, Chief Officer?
Yeah, yes, thank you very much, Chair. I'm happy to introduce that. But we did have a written update in June. Oh. So that's why this report looks pretty slight, because it covers the summer period, June to August. And the IJB's asked just to note the updated position and high level progress. The key update in relation to the whole system change programme is that you'll have heard at our development session, if you were present on the 15th of August, just Friday there, that the model of care has been approved as a final draft. It's a very large document. We have a whole range of materials produced, and there is a typo in this in the proposals. The material is coming forward later in this month to the programme board, and the proposal for the engagement plan that will follow that from October to December. The update also includes an outline of the learning disability community model of care, and confirmation that an additional programme director transformation post is about to close. It's out to advert at the moment, and that will work across the 3 health and social care partnerships in the areas that are referenced here. And there is an update in the appendix in relation to the transition work to secure the transfer of learning disabilities inpatient services from Strathmartin and Carsview to Murray Royal, and you'll see that the update there sets out a new phasing for that transition, and also references the model of care and the community model of care that's outlined briefly in the covering report. So happy to take any questions, and I think Jane Menzies may also be able to support in answering some questions as well. Thank you.
Who's going to be first? Nobody?
It's probably because this comes pretty hot after the development session that we've just had a few days ago. So, and we've had the opportunity to do that. So thanks.
Just Ben and I can't find is there a written paper for this? Because we don't have. Is that what you said?
Okay, as you say, Chief Officer, so I think you've found that supplementary report. It was just issued after the initial papers. As you say, Chief Officer, we had a development session last Friday where we talked a lot about the model of care, and we did have a good opportunity to ask questions of Dr. Lefebvre at that time. So if anybody's got any questions about this, just come in after the meeting. Oh, Mr. Black, you've got one.
It's really not just, it's a question, it's clarification in your previous strategic report, and we're talking about the SRF and then the 5 core principles, and the people principle, it's around people rather than system or services, but every paper then we get is about whole system review, and sometimes that could be a wee bit confusing.
I think that's a really good point to make, which is about the way in which we set out our intentions and our programme of work, which is usually about how we're going to go about it rather than the outcome necessarily. So we need to think about that and align our reporting against the service renewal framework and use some of those key headings so that we can set that out so there's clarity there, Martin. I hope that might be helpful to something for us to take away in our new reporting template as well.
Thank you. And Dr. Smith.
Just really a follow on from that. So again, we talk about involving the public in these discussions, and there's a lot about what we should do as services. There's probably less in there about what role the patients play in this and the public, and that obviously needs to be included as well, I think.
I think thanks very much for that, Danny. The work that lies behind this is very much inclusive and includes people with experience of mental health services within the design of it. So it's very much co-produced. That's part of the framework that sits behind this and the principles that we're taking forward. So we've probably taken it for granted in this report, but it's maybe something for us to think about. And while we're in, I think today the Share and Care Together are actually doing their summer tour in Angus, so they've got dates in Perth and Kinross, Angus and Dundee, which is very much about engaging with people in the community. So that's underway at present, and they're keen to come back and talk about some of their findings. So really just to say, if it doesn't come across in here, it's probably because we've really focused on that previously, but it's very much at the heart of what we're trying to do.
Okay, not seeing any further. Oh, Mrs. Summers.
There was a problem with the workforce and not being prepared to move. Is all the workforce issues being resolved now?
All I can say, Maureen, is that there is a period of organisational change that's underway, which will engage with every member of staff to support them in that move. So that's still underway. It's in process. It's not complete, but it's still in process.
It's not impacting on the plans. I mean, they're still going. They've still got a target date that they hope to achieve. Yeah.
I think that the update that's here today is saying that the dates will come forward and there will be a detailed report to the NHS Tayside Chief Executives team on the 1st of September, which will outline that, because you'll know the first target date was August 25, and that's so there's been a bit of a rephasing associated with that. So there will be a report coming forward on the 1st of September. We'll set that out. So that should be contained within the next quarterly update to the board.
Okay, thank you. With no other questions or comments, can we note the updated position and the high level progress update? Next item on the agenda. I'm just going to check. We might spend a bit of time on the adult services overview. Would people like a 10-minute break just now? Because we have been seated for coming up for an hour and a quarter. We'll take what time is it? We'll come back at 1:45, so 10 minutes exactly. Okay, thank you everybody. We'll get started again now, and we move to item 6.3 on the agenda, which is an overview of adult services. I'll pass over to Jane Menzies as the Head of Integrated Health and Care for Adults. Jane.
Thank you. Well, I guess previous discussions that we've had today frame the requirement for this paper. The best way to consider it is a sort of baseline in terms of where we are now and our intentions moving forward. So the paper touches on the services that sit within adult provision at their highest level. Obviously, there are a number of smaller services underneath those or subcategories. It then goes on to outline 6 key areas for transformation within adult services. But it is important to note that these 6 transformational areas sit alongside our usual improvement work that takes place as business as usual. A key aspect of this is always, as I said earlier, about safeguarding the care for the most vulnerable individuals within Perth and Kinross. But it's also about exploring services which are fit for the future and can, as efficiently as possible, or can allow us to use our resources as efficiently as possible. At the end of the paper, to ensure that the IJB has transparency and can hold us to account in terms of our progress, I make the suggestion that we continue to report in more detail on a 6-monthly basis. Thank you.
Thank you. Okay, have we got any questions about this overview of adult services? Councillor Frampton.
Thank you. I noted on it about the public dental services. I just wanted to know, going forward, will a representative from the public dental services be coming along to the IJB to give us updates?
Absolutely, that would be the case. We'll have managers from each of these services able to talk to them in detail.
Sold.
Thank you very much for this work. And can I ask a question about prison healthcare services? People who are on remand with mental health issues, do they receive treatment while they're on remand?
I have Dawn Wigley next to me, who is the service manager for prison healthcare, so I'll just pass over to Dawn.
Yeah, thank you for the question. I can confirm that those on remand do receive mental health care and treatment while they're in custody.
And a question online from Mr. Russell.
Thank you. Chair. Jane, thank you for the paper, and yeah, I broadly welcome the approach that you're setting out in terms of a focus on adult services. We often mention business as usual and transformation in the same sentence, and I'm just wondering how confident you feel that there is the necessary bandwidth amongst the staff group and the necessary improvement capacity within the partnership to support both business as usual and transformation.
Well, that's a key question. So absolutely, and that's something that we're considering more widely as a senior management team to make sure that those resources are in place, because you're quite right. We're seeking to take forward significant change with a workforce that's already under considerable pressure.
Would I be able to come back on?
I was just going to say a few words, Keith, as well, in that I think that capacity to support recovery in terms of our financial recovery, the capacity to support business as usual, as in the operations, and that transformation is a key challenge for us. And we are in the process of outlining what the additional resource that we might require to be able to achieve that, in the sense that it would be not a spend to save, but actually a spend to come in within a more comfortable position by the end of the financial year. So we're in the process of setting that out, and in discussions with particularly the Chief Executive and the executive team of the Council, and we'll also have a discussion early September with NHS side in and around how we can pull in support for that. Thank you.
Would I be able to
just come back in, Keith.
Jackie, thank you. I think that's a really important update, because readiness for change is an important assessment, and I wonder if in papers coming forward there might be an assessment on the infrastructure requirements that you feel is needed to deliver both business as usual and transformation, so that can come through these papers, so that we've got a good sight of whether that's been delivered or not. Thank you.
Yes, absolutely. Very happy to do that, Keith.
Councillor McCall's next, and then Mr. Black and Mr. Jones.
Thank you, Chair, and thank you, Jane, for the report. I noticed in the conclusion that you're proposing a 6-monthly basis update to this IJB, but given that the financial implications for these projects and these transformations are essential to the financial viability of the IJB, I'm just wondering if that frequency is too wide, and perhaps there's a role in terms of monitoring progress for the Audit and Performance Committee to perhaps have the capacity to do a little bit more detail on the interim basis. And if you're agreeable, Chair, then we could work together with unfortunately the Chief Financial Officer isn't here, but I'm sure she'd probably be agreeable with me. We could work together to see how that might be done without putting any onerous burden on the staff side. But I think 6 months is too wide, because 6 months from now, we're looking at the budgets will be set by then. So we do need to get a much better handle on where we are financially before that. So if officers are in agreement and you're in agreement, Chair, I'd like to bring that forward to the Audit and Performance Committee next week.
Thank you very much. I think that's something that would be a helpful addition in terms of the reporting. I think when Jane prepared this paper, we were thinking that the 6-monthly update was actually an improvement on the annual update that's been coming to the IJB. We do have an update on transformation to the Audit and Performance Committee that meets on Monday. So very happy to have a discussion around how we can do that and what that might look like. Thank you.
I think because we also look at audit performance, we look at risk and all of those other aspects in some detail. So I think to not include the transformation piece of work would be remiss of us. Thank you.
Thank you, and happy to discuss about frequency with the Vice Chair as well. Okay, it was Mr. Black.
Thanks for the report. There'll be no surprise that I'm going to 3.4 and about substance misuse. And it's well intentioned, there's a lot of good stuff in there, but the fact is you're only engaging with the Scottish Drug Forum again. And again, and I'll go forward, there's more problems with alcohol than there is with drugs. And it's no try to diminish either, but there's far more problems with alcohol. Where is the engagement with drug or alcohol partnerships within that? Again? I just find it strange it's not there.
Sorry, so there's a few things in there. The first is to say that we're working closely with colleagues in NHS Tayside to look at the development of a new alcohol pathway. The work with the Scottish Recovery Forum is only specific to the recovery orientated system of care, so that's only specific to that bit of work. And the Alcohol and Drugs Partnership are and will continue to be very much working in partnership as we take some of these changes forward. We have had a lot of discussion, and I would agree with you that the harm caused by alcohol is significant, and our plan is to put a greater emphasis on that.
Thanks for that. And I do notice in there that the shift from cocaine and that to synthetics is quite significant, and the fact that now the synthetics have been introduced into vapes. So they're starting to hit the young people at quite an early age in the vapes.
Okay, thank you. And then the next question was from the Vice Chair.
Thank you, Chair. Just one question. I note that the prison healthcare, the lead arrangements are separate from custody healthcare. Does that create any complexities in the pathways, having separate leadership?
Sorry. That is something that we're looking to progress moving forward to sort of bring that into one service agreement. So yeah, that would certainly be the preference.
Thank you. Just for awareness, the current integration schemes set that out separately with the forensic custody service sitting with that Angus Health and Social Care Partnership and IJB and prison healthcare with Perth and Kinross. But my understanding of the integration scheme is that can be with agreement of the 3 IJBs that can move around. So that's something we can take through the lead partner meeting that we were discussing that you asked about earlier. So yeah, we can take it there and then formalise that. But I think there would need to be a formal process that would acknowledge the role of the integration schemes in this. But for your reassurance, it's the same manager that runs those services. So Dawn actually runs those services.
I don't think you could get more integrated than that. Are there any more questions or comments on this report? No? Okay. Can we then note the current challenges and the transformation work streams established to address these, and that wider improvement work continues and is considered business as usual? And can we agree the accompanying recommendation to strengthen the associated reporting cycle, noting the point raised by Councillor McCall? Thank you very much. Next on the agenda then is thanks. Next on the agenda then is the Joint Carers Strategy Annual Update, and I think this report is going to be introduced by Zoe. Oh no, first is going to be introduced by Karen Sharp, who's the service manager. Karen.
Thank you. So this is the 12-month update of year 2 of our unpaid carer strategy, which supports adult carers, young adult carers, and we also dovetail with young carers. And we know the age span is from age of 5 right up to 92. So we have 7 outcomes, 6 dedicated to adult carers. So outcome 1 within the report, we have detailed the different ways that we have responded to unpaid carers, ensuring they have clear, reliable and accessible information. How we've depicted this within the report is how we have reached out individually or into communities. For example, page 40 of 120 is about putting carers on the map and also using national events. For example, Carers Week. And within the report, you can see how our dedicated teams have done their best to engage through community engagements, community support groups that were happening, information drops, and through GP surgeries who often will be working directly in identifying individuals who feel they are an unpaid carer. We've also acknowledged as a carer strategy group that being out and about in the community is critical to engage with unpaid carers, but we've also made sure that we have designed and which were influenced by unpaid carers are 5 topics, for example, which can be accessed online, which are looking after someone, carers' rights, hospital to home, emergency planning for carers and financial support for carers. So we do continue as an unpaid carer strategy group to continue to look at many a different way to reach out, and that's to support unpaid carers, often not to feel overwhelmed, because they will often tell us they feel that they are often treacle treading to when they have identified that they may be an unpaid carer. What we've also done in relation to the way that we have reached out, for example, over the last 12 months, is our carer centre have handled over 27,540 requests for information and advice. And there's actually a reflection within here that support services and how to access them. Unpaid carers often find that great difficulty on how to navigate that. Respite opportunities that they may wish to embark on. Financial support, which is absolutely critical. Guardianship and power of attorney if they choose or have that role. Information on their rights as a carer. Referral to the carer centre for universal services, and often the signpost to statutory team, statutory service intervention, signposting to other partner services, and the different events that unpaid carers have requested that we support them with. So what I would say on the back of that is that obviously deploys a response. It deploys the importance of the partnership working when we are meeting and greeting carers, and we are seeing an increase of how many reach outs that we are having through our different service interventions. Outcome 2 relates to improved provision of flexible personalised support. So that obviously involves when an unpaid carer decides that they do wish a support plan. So 1,622 unpaid carers were registered through our carer centre. That's been a 15% increase from June 2024. When it comes to statutory teams interventions, either directly, that does not capture the next figure does not capture the signposting, because not everyone decides to go forward. They may actually engage with our intake team, and it might be that advice was enough. But statutory teams, and this is a rolling caseload, have engaged with 692 unpaid carers. But we also appreciate that unpaid carers may decide to relinquish their role. It is rewarding, but it can be complex. Or it's a case of sadly their loved one had passed away, or may go into long-term care where our 24/7 care team wraps round the cared for person, along with still the involvement of the unpaid carer. So there's so many different ways that can translate. Within the report, it also reflects the unpaid carers, the variation in the support plans offered and developed, and how that we are responding to this through the number of actions. Now, one unpaid carer may have 5 outcomes, personalised outcomes they want to achieve with support, or actually it might mean that they have 1 outcome. That very much will depend on that individual. Another way that we've been reaching out is we do promote carers positive. We often don't always hear the best lived experience from unpaid carers if they are employed, and some unpaid carers may have to give up employment due to their circumstance. So what we did was, through our local employability networks, we as a strategy group reached out to, for example, over the last 12 months, 62 local employers to see if they understood about carers' rights, if they had policies and procedures to apply, for example, carers' leave or such like. Because most unpaid carers who want to and can work, they want to give their all and not see that as a deficit and not be treated in that way either. We are finding as a strategy group this has been a difficult one, because we are going out there engaging with different employers, but for the uptake of the carers positive and for them to be a carers positive employer, we are finding, even though we've been creative with the different local employers groups out there, we are finding that uptake of that has been quite a bit of a slow burn. Outcome 3, carers can expect that they are listened to and have their opinions valued. We respectfully have unpaid carers and carers representative on the carer strategy, and we also link in with other programme of work. Within the report, it also reflects the different ways that we have employed teams dedicated to support unpaid carers, and we do, due to that dedicated role, we do successfully, we don't have a turnover, we do successfully, that agile workforce, we do successfully keep people in post, and the dedication and that skill set and that experience that then they can bring to that personalised conversation that they will be having with the unpaid carer. It also, within outcome 3, makes reference in relation to terminal illness regulations. So that's day 1, the first contact with an unpaid carer, to offering the plan on day 2, to looking at what are the outcomes to be achieved on day 5 and completing that plan for the unpaid carer within 10 working days. The only way there would be discretion in that is if that is the unpaid carer who is the driver of that and wishes for that variation of timeline. So we have not breached that, but through our dedicated team that supports what is a very sensitive, and quite rightly it could be at crisis or it could be long-term planning. So within there, it shows the integrated teams and how we differently engage with unpaid carers, from the community to a hospital base, through our GPs, or it could be through our commission services. It all matters, because it's always a creative response for the lived experience for the unpaid carer. For outcome 4, carers can expect opportunities for them to participate as active partners. Respectfully, as I've said, we do have members within our carer strategy group and within other working group. We also continue to roll out different engagement and consultations to again influence how we step forward. I think again, on listening to our carers' voice representatives respectfully, I think there's still more to do in relation to that area. Outcome 5, carers can expect more opportunities for carers' peer support. We have within the report reflected the different ways that we interact. We have our carer support group within working teams, and the different ways that we engage throughout the community and meet and greet. Our male unpaid carers goes from strength to strength, and again, we will just keep looking at ways of how we step forward. Outcome 6, carers can expect improved provision of flexible and personalised support to support emotional and physical well-being. Again, another way that we have reached out is the menu of activities. I mean, we do ask rather a lot when we step away for unpaid carers to deliver. They may be expected to be the psychiatrist, the psychologist, the specialist in moving and handling, the district nurse, and that's about keeping their family together. So what we do is we deliver all we can when it comes to our menu activities through our carer services and other professional bodies, for example, of legal information, money management, moving and handling, and well-being, for example. So again, we listen to unpaid carers, and that menu of activities that is then rolled out, that could be within working hours or out with working hours, face-to-face or virtually. Again, we really do need to keep that agile, and we have done. So that menu activity continues to be rolled out. On page 48 of 120, the flexible personalised interventions, you can see many a way that we have actually reached out. We do notice, for example, that our Citizen Advice Bureau have very much had an increase in relation to unpaid carers presenting and looking for advice. Often that's about cost of living and the increase and often the financial pressures that being an unpaid carer. Now that could be a heating bill, a food bill, it could be, from what they've told us as strategic members, it can actually translate in many a different way. So it's good to know that again they know where they can go, or we will signpost, and being able to then respond, to be able to advise them how to go forward. In relation to we over the years from 2021 within the report, page 49, we have seen a decrease in relation to carers experiencing crisis when it comes to their loved ones whose next journey point may be going into 24/7 care homes. So you can see that we've been able to do our best and dedicate resources and our staff to intervene at an earlier part of their journey. Again, I would advise there is certainly more to do, but I would say that, you know, we are doing our best to get further upstream rather than the carer going into crisis. You are then losing planning and negotiation with that family member, the cared for person and the unpaid carer. So we will keep dedicating getting further up that journey. Technology enabled care, because we've listened today about lots of different services and lots of different interventions. It was the carer strategy group that had decided to invest in the virtual tech house. So and I know that technology, you know, it's not necessarily for everyone as an intervention, but it certainly can be embraced and enhanced. Necessarily frontline teams who move in and out people's homes in the community. So we invested as a strategy in that, and that means that you can take that assessment into your own home, and it might be for the unpaid carer to get a break, and technology might actually be able to enable that to happen. So it was this strategy, the unpaid carer strategy group, that actually took that forward. That doesn't take away from our physical environment in the smart flat. As I say, to be able to offer both, I think bodes as well. So that's where we are just now in year 2 of our 3-year strategy. As we move into year 3, together as a group, we will look at the review of the strategy and how we take forward. In September, we'll be looking as a collective group of what we offer just now and how we respond and how we take that forward. And again, that will be done collectively with unpaid carers, as their lived experience will influence what the next journey point is. Happy to take any questions.
Mr. Riddle. Thanks for that very detailed report. I'm referring to page 43. You talk about liaison with the GP communication group to improve identification. I just wonder how well that has worked. If you find that useful.
it's definitely very useful, and we continue to any information that we create, we will disseminate into the GP surgeries. We find it useful because it means that we know that we're reaching out with the GPs, looking after the health and well-being of the unpaid carer, and we get feedback from carers that when they're actually when they're looking at their health situation, or they're actually maybe unclear about what is having the impact, as much as they are dedicating, their life to being an unpaid carer, then, they're not necessarily saying that there could be a health deficit there, that they're putting their needs last. So we're finding that strengthening that relationship has certainly been beneficial, but we won't give up on that. There's still more to do.
Thanks for that. On the point of guardianship and power of attorney, and it's a minefield, quite honestly, having experienced the guardianship and power of attorney journey. Support is given to the carer in the guardianship role and how to go about it. Is there support given to the carer after the guardianship comes into place, where they have to put financial accounts in every year, and they have to provide invoices, etc., for everything that's going on? Is that support ongoing, or is it just pointing them in the right direction?
I think it would be both, pointing in the right direction, because there might be a private arrangement, but we do have from our own local authority guardianships that we review, and also private guardianships that we review. So with that liaison, you would have that dialogue, as you say, and it could be something to do with welfare, it could be something to do with financial. We also roll out the advice through our learning development programme that I've touched on, through our legal must-dos and understandings. So yeah, again, it would be an ongoing journey, but certainly from the reviewing officers, from the social work teams, we would reach out and respond if people were having difficulties. But you're right, it is very complex to experience.
Mrs. Campbell.
Thank you. Thanks very much, Karen, for the report. And as you know, both Maureen and I are very involved in the Carers Strategy Group, which is excellent. I just wanted to ask a question with regard to the carers assessment, and if there is a waiting time for that for an unpaid carer, if they're in contact, and how long they may have to wait for that assessment to be completed. Thanks.
As I say, Bernie, we do dedicate workers to that, but obviously with that increase, if people are coming from like a carer centre or other community services from universal into statutory, we really do try and turn that around within 28 days. And looking at the crisis intervention, we would be doing that sooner. There will be waiting lists, you're absolutely right. So that's up to us then to make sure that we look at, is somebody at is the unpaid carer at the planning and just looking at information, or are they looking at crisis? If it was the crisis end, we would be prioritising that and certainly not waiting 28 days. You would definitely be dedicating that staff member. Now that might be the absolute dedicated unpaid carer support worker, or we would broaden that out through our assessing teams. We would also be reaching out across the different localities or centralised teams to help one another if they've got resource issues. But there are waiting lists more maybe for reviews. Now that is a statutory requirement for us to respond to, and I know that Carers Voice is very helpful in reaching out and saying, look, there seems to be a challenge here. But as I say, we would prioritise that as best as we could.
Councillor McCall.
Thank you, Chair, and thank you for the report. I just want to comment, first of all, I think that's encouraging that there's been so much more engagement and that the strategy seems to be making strides. I'm particularly interested in outcomes 3 and 4. And you mentioned when you were giving us an update on outcome 4 that there's more to be done. Can you maybe expand on what the more to be done is, please?
So, Councillor, that's in relation to participation. I certainly think there is more. Absolutely, we respect unpaid carers as equal partners. But why I'm saying there's more to be done is we are still, through Carers Voice or our strategic members or teams, the unpaid carers, and we don't want people to, it is the right respectful mechanism, but we don't want people to end up thinking the only way I can get my voice heard is through a complaint, because to me we're too late. So what we need to do is make sure that there are more openings for unpaid carers to actually be influencing as an equal partner, either through transformation or what we do in existing, or even influences as we step forward with maybe a lower level change through Carers Voice. I mean, they always give us an invite to, we'll bring it along to the group because you'll have a specialist here that can advise.
Thank you. I have raised this before at this committee about reaching out to carers who are not members of Carers Voice or other organisation. From my own personal experience, and it's no secret in this room, I know that the vast majority of carers that I know do not participate in any kind of organised thing. And very often they, and I know of one recent case where someone who was a crisis situation wasn't offered any carer support at all. So I still think that there's something that needs to be done to try and quantify the total number of unpaid carers, and then design something that will reach out to all of those people so at least they know. Like, I've never been asked to participate in a survey, for example, not once in 20 odd years or 30 of being an unpaid carer. So and I'm known, not just as here as a councillor, but long before that. So I think there's, for me, I'd like to see in the final year of the strategy some progress being made towards how do we quantify the total number of unpaid carers that are out there and what they're preferred, how we can communicate with them. Now, they may not respond, but sometimes it's quite nice just to know that somebody actually realises you're on the radar. So if we can find some way of doing that, I think that would be a really, really good success factor for this strategy. Thank you. Thank you, Chair.
Summers.
At one time, GP practices used to be the first point of contact, and GPs, I'm not saying they had the responsibility, but they used to keep a register, of unpaid carers, and I believe they actually got paid for that, but that stopped, and I think the register stopped in a lot of practices at that time, but they are the first point of contact with the services, and it'd be good if they could be taught that this is something that they should do, like, just say that, or hand a carer, identify that they are a carer, if they're in about somebody that they care for, and give them a leaflet with the possible contacts,
Yeah, do you want to come back in quickly on that point, Councillor?
Just quickly, I think that's a really valid point, because very often, particularly if it's through illness, unpaid people become unpaid carers, either in the short term or sometimes the longer term, and they will have no engagement with the service here at all. And so I think that is a big gap. So I think that's a really good point. So maybe, and health board colleagues, it's something we need to think about, how we take that up.
And we'll go to Mrs. Auld next.
Thank you very much for your detailed report, and again, congratulations on some of the graphs included, particularly the decrease in breakdown and placements required by that. Just a question, and apologies for my lack of understanding. Do you support children as carers or just adults?
Thank you. So we're young adults, and adults the last outcomer for the youngsters. It is a joint strategy, but actually that would be children and family services that respond to that directly. But obviously we would do transitional work, because the young carer of yesterday often becomes a young adult carer of tomorrow. So that's why we do have the joint strategy. But no, my accountability wouldn't be directly responding to that.
And And do you want to come in, Aaron, as Chief Social Work Officer and the strategic lead for children and family service?
That's great, thank you, Chair. Yes, so the children's strategy is really housed within the partnership for children, young people and families. So there's an annual report that's received there, and also by the Learning and Families Committee as well. So we work really close with PCABs as well, who are our delivery partner in terms of supports for young carers as well. And there's a whole array of supports that are provided to young carers as well, but we do an annual report as well for them.
Thank you. Mr. Black.
Thanks. It's on page 49, the 120, the chart, the percentage of funded permanent placement. And we've got percentages. You have numbers. Because I'm always a great one that we've got percentages, that we have numbers to actually say what is the impact on that. Is it 100, is it 10, or is it? Because there must be some saving, even in the last year, 10.5% a reduction about care home packages.
Behind that, there will be numbers. Off the top of my head, I'm going to fail on that today. I do apologise, but yes, we would have actually what that meant for how many individuals. I do apologise for not knowing that off the top of my head.
Mr. Singh.
Thank you, Karen. Just one question from me in relation to the age profile of carers. How confident are you that we're meeting the needs of all unpaid carers? I'm conscious young carers are often well catered for, as are kind of older carers, but those in the middle sometimes really kind of struggle to kind of identify or have a natural place, and sometimes supports aren't always kind of geared towards them. So how do you think the strategy's aiding in that?
As I say, from the age of 5 up to 92, as it stands just now, I think we are responding well, but I think, Aaron, there would be more to do there. That's why we look at so many ways of how we would intervene. But I wouldn't see it as a strategic risk. But I think it's about being responsive to so many, I suppose, all the asks that unpaid carers will come to the table with, quite rightly, because what would work for their life. So I don't see it as a challenge or a risk, but I always think that there's more room to always be creative.
Okay, I don't. Mrs. Somerset.
I just wanted a clarification. You talk about the promoting the carer positive. Is that what used to be carer aware? And you know, employers used to get a little plaque to display to say that they were, you know, they had recognised, you know, carers in their establishment.
Yeah, but Bernie, they've actually got to have certain things in place. You're absolutely right to be that carer positive employer. And yeah, that was previously what it was known, but we do need to do more work on that and getting, I mean, we've even been to the Chamber of Commerce and things like that, you know, there is more work to do to engage employers. I mean, the benefits for them as employers are tenfold. I mean, that means that you're going to have a skilled workforce, an agile workforce, and very much a dedicated workforce. But as I say, year 2, it still seems a bit of a slow burn.
Okay, I'm not seeing any more requests for questions or comments. So can we then note progress to date on implementing the joint carers strategy and request an update in 12 months' time? Thank you very much. Item 6.5 is a verbal update from the Strategic Planning Group.
Thank you. We've got apologies from Nettie Sutherland today, and Nettie was going to give an update. We had the strategic planning group on the 10th of June, I think it was, and it was here in person in the Civic Hall. And we had a discussion about ensuring that the strategic planning group was becoming much more face-to-face in its engagement, and Nettie was, as co-chair of that, was quite keen to ensure that that's the way in which we developed the discussion, so that it was much more of a workshop activity than an online meeting, which has been the case previously. And that was quite successful. I think we had a presentation on the carer strategy update. Karen, I think you were went through that and took some feedback from the strategic planning group. And the other agenda item that was there was an update on the neurodevelopmental pathway from the new nurse coordinator, which was outlining a really positive direction of travel, but the strategic planning group were keen to see how that would be implemented in practice and what outcomes that was achieving. So a bit more to come from that, and the next meeting is due to be held. I think it's next week, actually. Thank you.
Okay, any questions on the strategic planning group update? Okay, we'll now move on then to verbal update from Councillor McCall as chair of the Audit and Performance Committee, and you can answer the questions that everybody was asking earlier.
Thank you. It feels a bit out of sync without having Donna bookending either side of it, but here goes. The last IJB Audit and Performance Committee was on the 23rd of June, and the next meeting is on the 25th of August, which is neither side of this committee meeting, which is a bit unfortunate because although the papers are available, including the minutes on PKC's website, and anyone can access them, we've not been able to bring them forward to this meeting. But of course, as always, anybody can go and look at it because it's in the public domain now, and anyone can attend the Audit and Performance Committee if they want to scrutinise any or ask any questions. As I said, it's unfortunate about the way these things have worked out, and so I've asked committee services that for the 26-27 timetable that we start looking at how we sequence in these meetings so that they can come forward in a timely manner. Because as things stand right now, the minutes won't come forward, I think, until the next IJB meeting in October, probably. So I think that needs to be done. Notwithstanding all of that, the minutes aren't available. There's a couple of things, a couple of points to note from the last committee meeting. We quite often get reports from lead partners outside of Perth and Kinross, but sometimes they'd be written papers but delivered by the chief officer. So I wanted to change that and requested that the authors of the papers attended themselves at our committee, which they did, and I was very pleased to welcome teams from Angus on their lead partner role, and from Fife, who supported our own internal auditor role. So that was very helpful, and we want to thank them for that. But and it's helpful for two reasons. One is obviously the reports that they wrote inside and out, but also it gave members of the committee the opportunity to question them directly, and particularly give some recommendations and suggestions. So, for example, Angus have agreed to make sure that they give a level of assurance on the reports that they submit, which wasn't there before, so they're able to take away some action. So I think that is a positive going forward to improve the robustness of the work of the committee. The main part of that committee was the draft annual accounts for 24 and 25. That included the annual governance statement and the unaudited annual accounts. And following due diligence of the committee, the chief financial officer was authorised to sign the unaudited annual accounts on behalf of the IJB. I think there was an awful lot of hard work done by all of the officers, particularly in the finance team. Mark, you're the only finance representative here, but having worked in finance before, I know how challenging it is to get year-end accounts all done and dusted and checked and double-checked and triple-checked and brought forward. So I think there's a lot of hard work and due diligence preparing all of that. So I wish to extend my thanks. I think we all should to the finance team. Previously on today's agenda was the 24-25 annual report for the Audit and Performance Committee. It was already presented by the Chief Finance Officer. I was going to do this before she spoke, but now I've kind of had to edit it. So, but as I said in the foreword to that report, a robust and committed Audit and Performance Committee is seen as fundamental to the IJB efficiently achieving its strategic aims. and the rest of my forward is quite long, so I won't read it all out. I'm sure you've read all the papers. You know, really does give my sincere appreciation to the wider work and to other members of the Health and Social Care Partnership, and indeed to Democratic Services, who provide a lot of committee support and help and advice and guidance. So that's there. And then just finally, just another reminder that we still have a public partner vacancy on the Audit and Performance Committee. So as always, I'm more than happy to hear from anyone interested. That's me. Thank you.
Thank you very much. Have we got any questions for Councillor McCall on the work of the Audit and Performance Committee? Mrs. Campbell.
Thank you. I just wanted to ask in relation to, I am part of the Audit and Performance Committee, I have to say, but where it references the lead partner Angus for, I think, primary care services. So in the report, there's a comment regarding the Tayside Continence Advisory and Treatment. To find out more with regards to that, do we bring that back to Angus, or is that something we would raise here? And my simple question is in relation to that, and it refers to individuals within Perth and Kinross, is the waiting times for that service. So I don't know if that's something we'd, or I would bring that up on Monday. Thank you. That's great.
Bring it up on Monday, because we can't really consider the papers for Monday's meeting today. That's what I meant earlier on about being out of sync.
Okay, got any more questions for Sheila? Thank you very much. Okay, move on to section 8 on the agenda, and I think this is the report that you were just referring to. So for information at 8.1, we have an update from Angus Integration Joint Board, or Angus Chief Officer Gillian Galloway, in relation to the lead partner services provided by Angus. Have we got any questions on that? So I've got a question. It was just the recommendation 3 there was that a further report describing the proposed new model of care for out of hours services be submitted to all integration joint boards for approval in December and 24 and February 25. And I just wondered if there was an update on that.
Thank you very much. I think the response that we had at the Audit and Performance Committee was that that was a piece of work that has now commenced, but it has been delayed. But I think there's a review of out of hour services, and I know Hamish might be more aware of the outcome of that at this point in time, because I know we do have a member of staff who's part of that review piece of work.
Yeah, there was a review conducted by 3 independent members of not Angus HSCP, and they've produced a report which hasn't been shared widely yet. I haven't seen it, but there's now a piece of work going on to redesign the service. But again, that's the early stages as far as I'm aware, and I haven't seen any costings attached to that.
Okay, thank you. Are there any other questions on that lead partner services update? And then we similarly have for information, the lead partner services update from Perth Kinross Health and Social Care Partnership. Any questions on that? Seeing any? Okay. Thank you very much. We'll then move on to the 8.3, which is our work plan and development sessions for 2025. Noting the further reports that we were discussing earlier, which will add on to the forward planner. Are there any questions on the planner? Not seeing any. Okay, so on the last two items on the agenda are just the to note the future meeting dates for 2025, and we'll be working very shortly to get dates for 2026 added in for so that members can get those penciled out in their diary. And for the future development sessions, that one actually does go through to the end of the financial year, noting that we'll be we've got October, December, January, February, March. The December, January and February ones will, and possibly March, will be particularly concerned with the budgeting process. Councillor McCall, do you want to come in?
I was just wondering about the 19th of December and how close that is possibly to a recess period, and whether or not that is a sensible date to have a development session.
Clark to the board.
I'll refrain from referring to my own Christmas shopping pattern. But I mean, I guess it's up to board members. I mean, I think that you're maybe referring to the specific, the council recess period, which we would be into, and I should say maybe the NHS has a recess period. But I guess it's entirely up to board members whether they feel that would be a date that people may start to go and leave. So it might be an idea to look at something different.
I think it was just really to have a look at it, just to see is it still practical, and will we have enough attendees available? That's all really.
Okay, thank you. That's noted. We'll take that discussion offline and let members know. Certainly, it's not only shortly before Christmas, but it's also 2 days after the December IJB meeting. So maybe moving that would be helpful. Okay, I think that's the end of business. This is my last meeting as chair of the IJB. So I just wanted to thank officers, members of the board, the public partners for the support I've had during my time as chair. Formally, the handover takes place at the start of October. I had started to make a list of people that had been supportive, but I kept thinking it would be invidious to do so because I would miss people out, and then I kept remembering more and more people, and it became a very long list. But thank you very much to the officers who've supported me and to the board members who've supported me in my time as chair. Thank you.
I also said I'd like to thank you for the help that you've given to unpaid carers over the years, not just for your period here as chair, but over the years. So, and we hope to see you here still.
Thank you. Could I say a few words as well, Colin, because you've been in this role, but you were the vice chair for some time, well, 2 years and ahead of that, and have a long history with the IJB, and I would like to thank you as chief officer, but on behalf of the team, for the support that you've given us, for your availability, for your dedication to this role. And I think your chairing of the IJB has really encouraged a participative opportunity for all members to take part, and I think you can see that in the way people have contributed, asked questions, and taken part today. So your ability to chair a very long meeting and to conclude within the timescale, even when we cut it short by half an hour at the beginning, is actually quite incredible. So I think that's a pretty hard task to follow, Brian. So really a heartfelt thanks, Colin, for all your dedication and hard work over the last 2 years and previous to that. And we look forward to continue to working with you in a different role. So thank you.
Thank you very much. Okay, and the meeting is closed. Thank you.